స్టార్ట్ చేసిన చూడండి.
Right, correct. They are working. IT people are working. In 2 minutes it will come.
చూడండి సార్ స్టార్ట్ అయింది.
I think it will start in 1 minute now. It is done. So good morning you all. Again there was some minor technical problem because of which there is a small delay in the start of the class. So now we will start with treatment of cancers, and as you know from the topic neoplasia that you have studied in pathology, cancers are malignancies. And why do we call them malignant? Because the rate at which they proliferate is so high that these cancerous cells and the cancerous tissue will outgrow the normal cells and lead to invasion of their surrounding tissues, interfere with their function, interfere with their structure, and finally get into blood vessels, go to different places in the body, establish their centers there, again hijack the nutrition there, cause tissue destruction there, and may ultimately lead to death. So how do we treat these cancers, and what are the principles of cancer treatment, at least the basics, and what drugs are available for treatment of cancers is what we will discuss over the next few classes, starting with the one today. So if you see the image that is being displayed for your view, you see that on the x-axis there is time, on the y-axis there is number of cancer cells, and the number of cancer cells starting on the y-axis from 10 power 0 going all up to 10 power 12. And one important thing is you can see that 10 power 12 has a mention of death. So if the number of the cells is 10 power 12 in most tumors, that is the time when actually death is reported. So if you see 10 power 0 and a little above that, maybe possibly 10 power 1, that is 100. 10 power 0 is one cell, but that is very difficult to identify when only one cell is there which is malignant. So you go to 10 power 1 here, so that is about 10 cells, then 10 power 2 about 100 cells. So we know that cancer cells actually, in fact like any other cell in the body, grow exponentially, but the rate at which the exponential growth happens is very rapid in the malignant cells. So in normal cells, the number of cells that are formed is actually exactly similar to the number of cells that are needed to be replaced. But in cancer cell, irrespective of the number of cells that are dying, excessive number of cells are being formed because of dysregulation in the cell cycle. And most of the cells, they pass through G0, G1, GS, G2, M. These phases they pass through. So G0, G1, S, G2, M. These phases the cell cycle actually passes through. G0 is the pre-synthetic phase, or the G0 is the resting phase. G1 is the pre-synthetic phase. S is the synthetic phase. G2 is the post-synthetic phase. So when the cell cycle, I am actually again cross-checking if the network is working or not, because there are some messages that I keep getting. So always it is a very complicated thing to keep a track of what we are saying and whether the network is live and whether the signal is working or not. So G0 is the resting phase of the cell. Most cells in most tissues will be in resting most often, except for the cells in the bone marrow, cells in the rapidly proliferating tissues like the gonads, cells in the skin, mucous membranes, hair follicle. There the cells will be mostly in the G1. So G0 is the resting phase, G1, S, G2, M. These are the phases through which the cell cycle passes. So the rate at which the cell cycle happens in the malignant cells will be very, very high as compared to the normal cells. Usually whenever a tissue becomes malignant, in that tissue the cells will be having a very rapid rate of proliferation, and when the number of cells reaches somewhere between 10 to 10 power 11, then the patient will start to have symptoms, and mostly the diagnosis happens around then. Unfortunately in the initial stages it is very difficult to diagnose, and by the time the number of cells becomes 10 power 12, the person may actually die. So there is a very small opportunity that is available from the time of diagnosis till the patient dies, before which we can identify and treat a patient successfully. And what do we see here is, if someone diagnoses a patient with cancer very early, for example here there is a diagnosis, and if someone can remove the tumor itself at that early stage, then what happens is the number of cells will dramatically fall. For example, if there are 10 power 11, 10 power 9 cells here, for example, 10 power 9 cells, and you have identified cancer very early at that stage, and if you remove the primary tumor, you see the number of cells will dramatically fall to 10 power 3 or 10 power 4, and subsequently it will keep falling to 10 power 2 because you are also giving chemotherapy. So immediately you remove the tumor and give the chemotherapy, then the number of cells will be maintained at a very low number and the person can actually survive for a long period of time. On the other hand, if you give treatment which is inadequate and infrequent, so that the number of cells, for example 10 power 11 is coming to say 10 power 9, so it is called log 2 reduction in the number of cells, because from example 10 power 11 to 10 power 9 it has come, it is 10 power 2 reduction in the number of cells. So that is called log 2 cell kill. Log 2 cell kill is where 10 power 2 number of cells are killed by the dose that you are giving. So it is called log 2 cell kill dose. And see, the frequency of the dose interval is also, the frequency is not very high, the dose interval is widely spaced apart. So if the frequency is low and the interval is high and the dose is also low, in that case what happens is temporarily there will be reduction in the number of cells, but the number of cells will again go back. Then again you give therapy, it will come down. Then again the number of cells will go back. Then you give therapy, it comes down. And if you further delay, even before you could give the next dose, the number of cells will go to 10 power 12, at which death may happen. So inadequate dosing and at long intervals of time if you do dosing, again it is non-productive. Though you may be giving a drug, the dose is not enough. Though you may be giving the drug, the interval is too far away between the two doses. Therefore, the number of cells will again catch up their growth rate to move towards death. And another thing is, if someone can get a large dose, see for example here 10 power 9, the number of cells have come back to almost 10 power 6 here. So log 3 cell kill. So if that amount of dose is given, the number of cells coming down is significant. And even before they could go up significantly, again you have given a dose, it comes down. Again you have given a dose, it comes down. Again you have given a dose. So here the cell kill dose that you are giving is also high and the frequency at which you are giving the dose is also high. So this is ideal. If you can give the dose which can kill a reasonable number of cells, and also very frequently if you can give, what you can do is you can dramatically lower the number of cells that are there in that malignant tissue, and that will help the person to live. So this blue line indicates the dosing is also reasonable in terms of being able to kill a log number of cells that are adequate to ensure that the cells don't catch up their growth rate and move towards the number that causes death. Whereas if you give low doses and infrequent doses, the cells will catch up their growth rate and they will accelerate their cell proliferation in such a way that the number goes up to 10 power 12 and the person may die. Initially if you pick up and if you can remove the tumor, that thing like it, because that is the best thing. If you can identify early and if you can remove the tumor, then the progressively number of cells will fall. Additionally, you may give treatment also, chemotherapy also. So this is the principle of treatment of cancers, where early detection matters. Early detection followed by, if option is there, surgical resection matters even more. If that option is passed and if you diagnose relatively late, then initiating chemotherapy and giving it aggressively by using appropriate dose to reduce the log cell appropriately and also adequately frequency wise giving the treatment matters. If you give less dose and if you give the dose at long intervals of time, then the treatment may fail and the person may actually die. So this is what is the principle of treatment of cancers. Now there are lots of drugs that are used in treatment of cancers. So there are cytotoxic agents, there are targeted drugs, and there are hormonal drugs. So what do we know about these cytotoxic agents, the targeted drugs, hormonal drugs? How do they act? What are the benefits? What are the risks? How long should we use? What drug interactions are there? Is all what we are going to discuss in the next few classes starting today. So first we will go to cytotoxic agents. So just overview of all these cytotoxic, targeted, hormonal is, cytotoxic drugs don't really have a specific target in the malignant cell. So in the malignant cell, they just target the DNA, and the DNA you all know is not only there in the malignant cell, it will be there also in the normal cell. So the cytotoxic agents don't have a very clear predilection for targeting only the cancer cells. They may as well harm the regular cells in the body also. So the difference in the dose only tells you whether it is going to be significantly toxic or it is less toxic. So because it is cytotoxic, it doesn't differentiate whether its cytotoxicity is limited to the malignant cells or its cytotoxicity is limited to the normal cells. Most often what happens is, in our treatment, whenever we are targeting the cytotoxic therapy, not only the cancer cells get killed, but even significant number of the normal cells in the body also get affected, and therefore the cytotoxic agents generally do not have a clear discrimination between the normal cells and the abnormal cells. The targeted drugs, they specifically target certain pathophysiological mechanisms inside the malignant tissue, and those pathophysiological mechanisms, when they are targeted, what happens is you will get relatively more specificity of anti-cancer drugs, because those pathophysiological mechanisms will not be commonly expressed in the normal cells. So when you give these targeted drugs will relatively more specifically affect the cancer cells and spare the normal cells. So there we get more refinement in our anti-cancer action. Hormonal drugs, because there are certain hormonal influenced cancers, certain hormones act as nourishment for the cancers to grow, and if we can cut off those hormonal influences which provide nourishment to the cancers. For example, estrogen actually accelerates the growth of estrogen receptor positive breast cancer. Endometrial cancer depends on estrogen. Then prostate cancer depends on testosterone. So if you can actually cut down these hormonal stimuli for those cells in these particular tissues to accelerate their rate of proliferation, in such conditions hormonal therapy also helps. So broadly, if you divide, anti-cancer drugs fall into three categories. One is cytotoxic agents, and these are relatively more toxic because they don't have much ability to distinguish between a normal cell and an abnormal cell. Targeted drugs are far better because they target certain pathophysiological mechanisms which are unique to the cancer cells and therefore can spare the normal cells. Hormonal drugs, they will be useful in hormone dependent cancers, where you remove the hormone action on those particular cancerous cells, because that hormone acts as a stimulus for those cancer cells, and therefore you can actually reduce the rate of growth of those cancer cells. Now once you understand what is the cytotoxic agents principle, the targeted drug therapy principle, and the hormonal drug therapy principle, we go to discussing the cytotoxic drugs. And in that, the first category of drugs are alkylating agents. From your knowledge of chemistry, organic chemistry in particular, you know alkyl is alkane with one hydrogen being removed from it. For example, methane CH4, if you remove the hydrogen from it, one of it, CH3, C2H6, if you remove one hydrogen, C2H5, ethyl. So alkylating agents have one less hydrogen, and what happens is, whenever a saturated compound is there, for example CH4 is there, now CH4 has 4 valencies of carbon saturated. So if you remove one hydrogen from it, then one of the valencies of the carbon is available, so that can be used to bind to some other radical anywhere. So these alkylating agents, because they have one valency still available to bind to some other radical, they are in a position to bind to carboxyl group, hydroxyl group, amino acids, phosphate groups, and sulfhydryl groups. Why are they able to bind? Because the valency of the carbon is not fully saturated. We removed one hydrogen from the alkane. So when you remove one hydrogen from the alkane, the carbon automatically will have one valency available. So it has got now the functional capability to bind to anything like a carboxyl group, like a hydroxyl group, or any other amino acids, or phosphates, or sulfhydryl groups. Now where is the main site of these alkylating agents in the cell? The alkylating agents in the cell, they act primarily in the DNA. And in the DNA, where do they act specifically? If you have a PG entrance question, that will be N7 of guanine residue. So you know the DNA is made up of A, T and G, C, that is adenine, thymidine, guanine and cytosine. So A, T, G, C, these combinations. So there alkylating agents have got the capability to bind to especially the nitrogen in the 7th position of the guanine residue. So N7 guanine residue is the primary site. Now why do you think this is the primary site? Why the N7 of guanine residue is the most favored site of binding of alkylating agents? That is basically because all these alkylating agents are having the ability to bind to electron rich sites, and N7 of guanine residue is electron rich. It is nucleophilic. So the N7 of guanine residue is highly nucleophilic, whereas alkylating agents, they are highly electrophilic. That is, they have the ability to go and bind to the place where excessive electrons are there. So all alkylating agents are highly electrophilic, and the DNA, especially the N7 of the guanine residue, is nucleophilic. You know from your knowledge of chemistry that nucleophilic is where rich source of electrons is there, and electrophilic is those compounds which have the affinity to bind to electrons. And now there is a electrochemical type of a affinity here, because the DNA is highly rich in the electrons, and these alkylating agents are highly electrophilic. They are searching for where are the electrons, and when these alkylating agents reach into the cell, when they go to the DNA, they find it a very favorable site. Natural affinity is there for going and binding to the N7 of the guanine residue. And when they bind to the N7 of the guanine residue, you know these ATGC complexes are considered to be very sacred, sacrosanct type of relationships those are. A will bind to T and G will bind to C. If anything comes in between and binds to them, the DNA recognizes that it is abnormal, and the three-dimensional delicate structure of the DNA collapses. So anything that is added other than the usual linkages that are there between AT and GC, the DNA molecule loses its three-dimensional stability, collapses, and that is how the cell dies. So these alkylating agents are crude molecules. They get into the malignant cell, and after getting into the malignant cell, they target the DNA. Which portion of the DNA? They target the nucleophilic regions, that is electron rich regions, that is the N7 of the guanine residue. And after binding, what do? They alter the three-dimensional geometrical stable structure of the DNA, and the DNA collapses. And when the DNA structure is lost, you know the cell cannot survive. It initiates the process of cell death, and that is how these drugs are cytotoxic in nature. And the thing is, these drugs do not have the ability to distinguish between a malignant cell and a normal cell. So there is a very thin line that distinguishes a dose that is killing only the cancer cell and a dose that actually kills the normal cells. But still, they will be able to preferentially inhibit the cancer cells relatively more than the normal cells, because the cancer cells rate of proliferation is very high. Not only the rate of proliferation is very high, the rate of uptake of everything including nutrients and non-nutrients is very high. So when you give an alkylating agent to a patient who is having cancer, if normal cells take up this in a certain proportion, the abnormal cells, that is the malignant cells, take up in multiple proportions of that. For example, if a normal cell picks up X amount of the alkylating agents, the malignant cell may pick up 10x, 20x or 200x of the alkylating agent, because the surface molecules on malignant cells for transport of so many substances including nutrients are so highly expressed that they keep picking up lot of stuff into their cells, including the alkylating agents. So when the alkylating agents actually enter into the cell, these alkylating agents are then able to target the DNA, the N7 of the guanine residue, and after going into the N7 of the guanine residue, they alter the geometrical three-dimensional structure of the DNA collapses, and that is how they get the pharmacological action. So if anyone asks, describe the mechanism of action of an alkylating agent, it should be very simple for you. There are certain key aspects of alkylating agent that you need to remember now, which I will emphasize. All alkylating agents, unless and until I specify, are prodrugs. Most alkylating agents, unless and until I specify, they are prodrugs. And all these alkylating agents have rapid uptake into most cells in our body, and the rapidity of uptake is much more in the malignant cells than in the usual cells. Not that it doesn't go into the normal cells, it will go, but the rate at which it goes into the malignant cells and the amount it goes into the malignant cells is much more than the amount that goes into the normal cells. The third one is, are they cell cycle specific? Do they act during specific phase of the cell cycle? No, they act at all phases of the cell cycle. So that is one limitation. That is how their toxicity is little more, because they don't have any specific phase of the cell cycle like G1, S, G2, M. Do they act anywhere? It's not like that. They can act at any phase of the cell cycle. So even resting cells will be affected by them. Not only the proliferating cells, even the resting cells will be affected by them. And the other thing is, when I say these are prodrugs, most of them, then where is the site in the body where they become active? Most of them become active in the liver. And what happens when you give these drugs get activated in the liver, and the active form is then taken up by the malignant cells and to some extent the normal cells, and then binding to the DNA, the N7 of guanine residue, and then the cell dies. So first we go to these compounds called nitrogen mustards in alkylating agents. These nitrogen mustards, these are actually organic compounds with nitrogen in their structure. Especially if you see, the classic nitrogen mustard was a chloroalkane. So chloroethyl amine it was. Nitrogen is there, hydrogen is there, carbon is there, and chlorine is there. So these were used in war. These were used in war for causing blistering on the surfaces of the people who inhaled these gases, and the people used to get severe excoriation of the skin, mucous membranes, dehydration, and death. So nitrogen mustards, why are they called mustards? Why are they called nitrogen compounds? We know, because there is nitrogen in them. These are nitrogen containing organic compounds. Additionally, chlorine is present in mechloramine with the first one. So why are they then called mustards? Because all of these compounds which were used initially in warfare as harmful gases, these compounds smelt like mustards. So mustard oil and mustard seeds, they smelt like them, and therefore these were called nitrogen mustards. Mechloramine is one of the alkylating agents which was used as a war gas, as also a liquid. It is actually liquid. At high temperature it becomes a gas. So in war they used to use special mechanisms to convert this liquid into a gas, and that gas used to cause the toxicity in the individuals who used to inhale it. All the mucous membrane, skin, everything undergoes desquamation because of epithelial erosions, and then because of the lack of integrity of the skin and mucous membrane, the person will lose lot of volume of water from the body, and then dehydration, acute renal failure. That is how the mechanism of death used to be in those individuals. Mechlorethamine is available as a liquid. Mechloramine is a liquid. Mechloramine is used for IV route of administration only, and it is a highly irritant compound, so therefore cannot be given by any other route. Only IV is the route. IV, when you give, the volume of blood is so high at any point of time, so that the drug gets diluted, so the effects will be less in terms of the irritant effect of this compound. So therefore mechloramine is used only IV. Is it commonly used nowadays? Is not used commonly nowadays because of its high toxicity and vesicant nature. When you are giving IV, if it spills over onto the skin, it will cause severe erosions on the skin. So that is the reason why this compound is not used now. If at all it was used, in what type of conditions was it used? It was used in treatment of leukemias and lymphomas. What is the problem with this compound mechloramine? Severe vesicant nature. Vesicles will be formed and it will lead to excoriations and inflammation, and that is the reason why it is not used. The only route of administration for that was IV. And did it cause any other adverse effects? All anti-malignancy drugs, now I will tell you, cause certain adverse effects, more so the cytotoxic agents. So unless and until there is a specific adverse effect that is mentioned, you can blindly write these as adverse effects of most cytotoxic agents. The first is, most cytotoxic agents cause lot of tissue destruction, and because they cause lot of tissue destruction, cytokines that are released as a part of the tissue destruction can trigger nausea and vomiting. So most cytotoxic agents, they cause significant amount of nausea and vomiting. You may write nausea, vomiting anywhere or not, but in anti-malignancy drugs, if you write, that is considered as a very welcome type of note that you have written there, because they indeed cause significant amount of nausea and vomiting. Apart from them, these drugs act on the bone marrow, and then in the bone marrow they will lead to depletion of the bone marrow cells, the bone marrow suppressant effect, and they will lead to leukopenia, anemia, and thrombocytopenia. So this is classic. Bone marrow is most vulnerable because the rate of proliferation of cells in the bone marrow is high, and therefore those cells get affected first whenever you use cytotoxic drugs. Next is the skin and mucous membranes get affected, because even there the rate of proliferation of the cells is high. Next is skin appendages, the hair follicle, their rate of proliferation gets affected, and therefore alopecia is also common. So if three important adverse effects of most cytotoxic drugs we have to remember: one is the bone marrow depression, bone marrow suppression leading to leukopenia, anemia, thrombocytopenia. The next one is skin and mucous membranes undergo epithelial cell loss leading to diarrhea if it is the GI mucous membranes that are affected, and leading to vesicle formation and excoriations if skin is involved, and hair loss because of the hair follicle will be involved. The third one is the gonads also have high rate of proliferation, so they may lead to infertility, and consistent anti-malignancy dose in large amounts can actually lead to sterility also. So infertility and sterility, the only difference is infertility has causes which are predominantly reversible, sterility is irreversible. So initially it will be infertility, later on it could become sterility. Then the other thing that you will have is, with these compounds, increased risk of infections, because again that is secondary to leukopenia, and increased risk of infections, bacterial, viral, fungal. The most important thing is these compounds themselves can increase the risk of malignancies, because in our body we have certain cells which are called natural killer cells, and there is a surveillance against cancer cells. So when we have cancer cell surveillance in our body that is ongoing, and you know these cancer cells can actually lead to not only infiltration into other tissues in our body, they may actually infiltrate if, for example, there is a leukemia, and if that leukemia is having very high acute rate of proliferation, those leukemic cells may interfere with the bone marrow function itself, and there may be less number of natural killer cells, so it may actually increase the risk of cancers. So apart from that, whenever any person is taking any alkylating agent themselves can also increase the risk of cancer. So cancer treatment agents can increase the risk of cancer. How can cancer treatment agents increase the risk of cancer? Is basically because these drugs, they remove lot of cells from our body which are normally functioning, including the cells that are responsible for immunological surveillance against cancer cells. So even if the cancer cells are developing initially, sometimes our natural killer cells will try to take care of them and will try to eliminate them. But if alkylating agents are given, alkylating agents will eliminate even the natural killer cells which act as surveillance cells against any developing cancer. So they not only actually treat cancer, but they may predispose a person to another cancer. So in examination sometimes they ask, can any anti-cancer drug actually cause cancer risk to be elevated? Alkylating agents increase the risk of cancers also, secondary cancers. So that is what we have to remember. So bone marrow depression leading to leukopenia, anemia, thrombocytopenia, then mucosal erosions, then hair follicle rate of proliferation becoming slow leading to alopecia, then gonadal function going down and leading to infertility or sterility, and then the risk of malignancies. These are important adverse effects of most cytotoxic drugs. And for each one of these drugs I will tell you what is the dose limiting toxicity. Of course, for mecloramine or meclorethamine, it is also called meclorethamine. So you could have actually sensed while I was telling mecloramine, I was actually sometimes telling mecloramine, sometimes meclorethamine. So meclorethamine is another name for mecloramine. Some people call it mecloramine, some people call it meclorethamine. So mecloramine or meclorethamine is a nitrogen mustard, is an alkylating agent in the broad category. Then it is a nucleophilic compound. It is a electrophilic compound, and it goes and binds to the nucleophilic DNA and collapses the structure. It is highly vesicant, given only intravenously, can cause discoloration of the skin at the site where it is being administered if it accidentally falls, and because of its highly irritant nature, it is no longer used. It was used previously in treatment of leukemias and lymphomas, and it can cause bone marrow depression, it can cause alopecia, it can cause severe nausea and vomiting, it can cause mucosal erosions, it can cause infertility, it can cause sterility. Now go to another compound called cyclophosphamide. Now this is used widely, cyclophosphamide, both as anti-cancer drug and immunosuppressant drug. So some people may ask you, why is cyclophosphamide used as an immunosuppressant drug? Cyclophosphamide is used as an immunosuppressant drug because, as I mentioned, these alkylating agents can act on every cell in the body, especially the rate of proliferation of the cells. If it is high, those cells are more vulnerable to the action of alkylating agents, and cyclophosphamide can easily act on the bone marrow, and in the bone marrow it can lead to suppression of the T cells and the B cell production also, and therefore it will lead to immunosuppression. So in a very tightly regulated dose, very meticulously controlled dose, in a small dose, if you give cyclophosphamide, it may independently act as a immunosuppressive agent also, and widely used as a steroid sparing agent, because steroids also cause immunosuppression, but steroids have lot of adverse effects on multiple tissues in our body. So initially if we use steroids, and later if you want the person to be spared of the complications of steroid for long-term treatment, then we initiate the person on cyclophosphamide, because cyclophosphamide has immunosuppressant effect but doesn't have the type of side effects like steroids. For example, if I am a person who has vasculitis and I have vascular involvement of the blood vessels, inflammation, kidney and the lung, then I may be having hematuria, I may be having massive bleeding into the alveoli, alveolar hemorrhages, and it is an autoimmune condition for which there is no treatment except to suppress the immunity by giving steroid. But if we keep on taking steroids, I may develop osteoporosis someday, I will develop diabetes, I may develop hypertension, I may have poor wound healing, I may develop peptic ulcer. So because of this, long-term steroid, whenever it is indicated, there cyclophosphamide can be used, because it will have immunosuppression but it will not have the same effects like steroids. So cyclophosphamide, apart from anti-cancer, is also a very significantly used, clinically used immunosuppressive agent. The dose is very clearly distinguishable. Little higher dose will cause anti-cancer effect, a little lower dose can cause immunosuppressive effect. So cyclophosphamide can be used for both anti-cancer as well as immunosuppressive action. Now cyclophosphamide, again, like all the drugs that I told you, alkylating agents are prodrugs, and because these are prodrugs, they all go to the liver, get activated in the liver, and what happens after they get activated in the liver? After getting activated in the liver, they actually have the ability, now one carbon atom valency is free, and that can bind to any other radical like the carboxyl radical, the hydroxyl radical, the amino acids, the phosphates and sulfhydryl radicals. And not only in the nucleus, wherever in the cytoplasm or in the nucleus, other proteins, wherever they can find these radicals, they can bind. And therefore cyclophosphamide is supposed to be generating something called as a carbonium ion. Carbonium ion, you know sodium ion, you know potassium ion, you know chloride ion. There is something called carbonium ion also. When the carbon atom actually gains a positive charge, it is called a carbonium ion. You know, when CH4 is there, you remove one hydrogen, automatically the carbon will gain a positive charge, and that is why they are called alkylating agents, and that is why they have very, very high electrophilic action. They will be searching for electrons, and there is where they will find in the DNA the electrons in the N7 of the guanine residue. So cyclophosphamide is a prodrug. It is possible to be given orally as well as IV. That is a big difference with the meclorithamine or mecloramine. Mecloramine could not be used orally because of highly irritant nature, where cyclophosphamide can be given. It doesn't have the type of irritant potential. In the liver, it gets converted into its active metabolites. Those are called aldophosphamide and phosphoramide. Aldophosphamide. So instead of cyclo, you should write aldo. Aldophosphamide and phosphoramide. Phosphor, PHOSPHOR, phosphoramide, AMIDE. So phosphoramide and aldophosphamide are active forms of cyclophosphamide. And cyclophosphamide, when it is taken up by the malignant cells, again the fate is same, goes into the nucleus, targets the N7 of the guanine residue. It can also additionally bind to certain carboxyl, hydroxyl, amino acid, phosphate or sulfhydryl groups and lead to lack of their function also, interfere with their function also. Now cyclophosphamide has got certain peculiar features. Cyclophosphamide has got a metabolite called acrolein. So the active form of cyclophosphamide is aldophosphamide and phosphoramide, but the active metabolites apart, there is another metabolite which is inactive but which is toxic, and that is called acrolein. So in terms of cyclophosphamide, you should remember the metabolites which are active and the metabolites which are inactive but which are toxic. So aldophosphamide and phosphoramide are active metabolites. They are responsible for the pharmacological action. They are responsible for the anti-cancer action. But there is another metabolite of cyclophosphamide called acrolein, ACROLEIN, acrolein. This acrolein has the ability to cause hemorrhagic cystitis. This acrolein is excreted in the urine and it can lead to hemorrhagic cystitis when it comes in contact with the epithelium of the bladder. It is an irritant to the bladder epithelium and it will lead to hemorrhagic cystitis. This is a very common question, most often that is asked. Mention one drug which can cause hemorrhagic cystitis. The person will come with blood in urine, and that one drug which can cause this is cyclophosphamide. If cyclophosphamide people don't write hemorrhagic cystitis, it is not cyclophosphamide. And do we really get hemorrhagic cystitis in the immunosuppressive dose that we use, or do we get it in the dose we use for treatment of cancers? Generally we get it in the dose that we use for treatment of cancers, not much in the dose that we use for treatment of autoimmune conditions. Then, is there any way you can reduce or minimize the risk of hemorrhagic cystitis? That is another question that is very commonly asked. Yes, because the metabolite acrolein that is formed can be neutralized by giving any compound which has a SH group in its chemical structure, and the compound that we use is called mercaptoethane sulfonate, MESNA, mercaptoethane sulfonate. Mercaptoethane sulfonate has several SH groups in its chemical structure, and these SH groups, they bind very avidly to the acrolein molecule, and then the acrolein becomes inactive. Its ability to bind to the epithelial cells on the bladder surface and cause hemorrhagic cystitis dramatically gets reduced. So what can be done to reduce the risk of hemorrhagic cystitis with cyclophosphamide is co-administer compound called MESNA, mercaptoethane sulfonate, MESNA, mercaptoethane sulfonate. So that is very important principle of ameliorating the toxicity of anti-cancer drug. There are a lot of anti-cancer drugs, there are a lot of side effects to different anti-cancer drugs. Some anti-cancer drugs have very specific adverse effects, and there are some remedial measures to neutralize the effect of such specific adverse effects. One such case example is cyclophosphamide, where the specific adverse effect of hemorrhagic cystitis could be significantly reduced by co-administering MESNA. Now anywhere cyclophosphamide is asked, and if people don't really mention this, it reflects very poorly on the overall knowledge of cyclophosphamide. Then cyclophosphamide, is it emetogenic or not emetogenic? Highly emetogenic. The moment you give cyclophosphamide, within hours the person will have tremendous amount of nausea and vomiting. So before giving cyclophosphamide, usually pre-medicated with 5-HT3 receptor antagonists like ondansetron, palonosetron, dolasetron, because those are the agents that will relieve nausea and vomiting due to chemotherapy. So one important thing is, usually most drugs that are used for nausea vomiting may or may not work in people with chemotherapy induced vomiting, but chemotherapy induced vomiting drugs of choice are 5-HT3 antagonists like ondansetron, dolasetron, palonosetron. So those work very well in vomiting induced by cyclophosphamide. Then people thought, this cyclophosphamide, does it have effects? So I am not mentioning the other general side effects. You know hemorrhagic cystitis, you know nausea, vomiting, but the other side effects in terms of bone marrow depression, leukopenia, anemia, thrombocytopenia is there. The other side effects like mucosal injury and GI distress and diarrhea is there. The other thing in terms of alopecia is also going to be there. The other thing in the long term of infertility and sterility is also there. Those are all the common effects of most cytotoxic agents, but what stands out prominently and exclusively is what I am emphasizing for cyclophosphamide. And what is that which stands out prominently? Two important things is highly emetogenic, and the next one is hemorrhagic cystitis. So there was a modification to the cyclophosphamide, and then the next phosphomide. So this ifosfamide, do we have any advantages as compared to cyclophosphamide? Was ifosfamide intended not to cause hemorrhagic cystitis? Did we achieve the goal of preventing hemorrhagic cystitis? No. Ifosfamide is quite similar to cyclophosphamide in its ability to cause hemorrhagic cystitis. Then what is the advantage of ifosfamide? Why did they even make ifosfamide if there was no significant reduction in the risk of hemorrhagic cystitis with ifosfamide? Ifosfamide has got two clear advantages over cyclophosphamide, and that is the reason why you need to know about ifosfamide. One is the risk of nausea and vomiting is low with ifosfamide. It's quite low with ifosfamide as compared to cyclophosphamide. It's not that it is not there. Don't write in the examination that ifosfamide doesn't cause nausea vomiting. That type of sweeping statement, generalizable statement should not be made in anti-cancer drugs. Relatively, when you compare cyclophosphamide versus ifosfamide, ifosfamide's ability to cause nausea vomiting is low, but doesn't mean that ifosfamide is absolved of the side effects of nausea and vomiting. It still causes nausea vomiting, but much lower than that of cyclophosphamide. The next one is alopecia risk is low with ifosfamide. This is a PG entrance question. The only two key features that distinguish ifosfamide from cyclophosphamide are alopecia is less with ifosfamide, and hemorrhagic cystitis is same as cyclophosphamide, and then nausea vomiting is less with ifosfamide. So if someone asks bone marrow depression, is it less with ifosfamide? No, it is same as that of cyclophosphamide. Hemorrhagic cystitis, is it low with ifosfamide? No. Is infertility risk less with ifosfamide? No. Is risk of secondary malignancy is less with ifosfamide as compared to cyclophosphamide? No. Is alopecia risk less with ifosfamide as compared to cyclophosphamide? Yes. Is hemorrhagic is the risk of nausea vomiting less with ifosfamide? Yes. Of course, hemorrhagic cystitis risk is same whether you use cyclophosphamide or you use ifosfamide. And between cyclophosphamide and ifosfamide, which is more potent? Cyclophosphamide is more potent. You need to use in lower doses. Ifosfamide you need to use in higher doses. Ifosfamide generally is used IV. Cyclophosphamide can be used both oral and IV. These are differences. See, whenever you compare and contrast some things, the knowledge part of it going to comprehension, analysis, application becomes easily analyzable. So if someone has to know to what extent you have understood cyclophosphamide, ifosfamide, rather than asking simply ifosfamide, rather than asking simply cyclophosphamide, the best question to ask you will be compare and contrast cyclophosphamide and ifosfamide. That will tell us that you not only know, you also understand, you can also apply this knowledge. So compare and contrast. Comparison is similarities and differences. Similarities, both of them are alkylating agents, both of them are prodrugs, both of them get activated in the liver, both of them get into the cell, both of them have the same mechanism, both of them are highly electrophilic, both of them bind to the N7 of the guanine residue. Apart from this, they can bind to carboxyl group, hydroxyl group, amino acids, the proteins, then the phosphates and the sulfhydryl groups. They can collapse the structure of the DNA. They don't have any specificity for the normal cell versus abnormal cell. Then where do they differ? Cyclophosphamide and ifosfamide differ in terms of some side effects, especially nausea, vomiting being less with ifosfamide, alopecia being less. On the other hand, if you look at the bone marrow depression, if you look at the mucosal injury, if you look at the infertility, all of them are same. And if you look at the risk of secondary malignancies that may develop, all of them, they are similar, whether it is cyclophosphamide or ifosfamide. Which is more potent, which is less potent? Ifosfamide less potent because you need to use larger dose, cyclophosphamide more potent. Now, if this much is known about these two compounds, I think that is a very significant stride that you might have taken in terms of describing alkylating agents, because really the two most important things here are cyclophosphamide, ifosfamide. Mechloramine or mechlorethamine no one uses nowadays. The other one is chlorambucil. Now I will tell you the specific features of chlorambucil. Chlorambucil is a very slowly acting alkylating agent. So of all the alkylating agents that you have, chlorambucil is a slowly acting alkylating agent. Why is this point of slowly acting alkylating agent of chlorambucil useful to us? So how does it differ, sir? If it is not a fast acting agent, why should I know? Your question should be that, why should I know if it is slowly acting? Why are you even mentioning that it is slowly acting? Why I am mentioning is because the drugs which are rapidly acting can be used in malignancies in the acute phase. Most malignancies have a remitting, relapsing type of pattern. So we always give cancer treatment in two phases. One is the acute phase, which is called as induction phase, where we give a large dose and kill large fraction of the cells. Next is the maintenance dose, because once you kill a large number of cells, you wouldn't have eliminated all the malignant cells. There may be some cells which have escaped the action. They may be very small, they are undetected, so they will start to come up and they will again become 10 power 5, 10 power 8, 10 power 10, 10 power 12. Again you will get into the risk of the patient dying. So therefore, to constantly suppress even the remaining cells which escaped the induction dose, what we do is give a suppressive maintenance dose. So there, the induction dose and maintenance dose, the choice depends upon whether the drug is rapidly acting or whether the drug is slow acting. If the drug is rapidly acting, then we give it in the induction phase. If the drug is slow acting, it should be reserved for the maintenance phase alone. It should not be used in the induction phase, because in induction phase the tumor burden is very high. You need to immediately reduce the tumor burden within a very short span of time, otherwise the tumors will go away from control. The rate of proliferation of the tumors is exceptionally high and is exponential. So initially, when you want to induce the remission in an individual, best is to use drugs which have a ability to kill large number of cells. So their log cell kill fraction should be very high, at least 10 power 2, 10 power 4, 10 power 6. So log cell kill proportion, the higher it is at induction, the greater will be the reduction in the tumor burden, and then the subsequent maintenance dose required will be less. So chlorambucil, if anyone asks you, is it used for induction or is it used for maintenance? The answer should be maintenance. And if say give reason why it is not used for induction, why it is used for maintenance, the answer should be chlorambucil is a slowly acting anti-malignancy agent. Another important thing about chlorambucil is chlorambucil not only acts slowly, chlorambucil is quite specific for the lymphoid series in our bone marrow. It is not really very specific for the myeloid series, and therefore it is used in treatment of mostly lymphocytic tumors. Now you may ask, sir, why did you choose to say lymphocytic? Why did you not say lymphoblastic? If you understand pathology's distinction between what is lymphoblastic and what is lymphocytic, lymphoblastic is really a very, very undifferentiated type and a serious type of malignancy, whereas lymphocytic, the cells have reasonably got differentiated and only the rate of proliferation of the cells is high. Malignancy is always two things will be there. One is rate of proliferation, other is differentiation. If differentiation is poor and rate of proliferation is high, that is a devastating type of consequences will be there. If the differentiation is reasonably good, even if the rate of cell proliferation is high, the person will survive better. That is the difference between acute lymphoblastic leukemia and acute leukocytic leukemia. That is the difference between blastic and cytic cells. Generally, whenever you have cytes, it will be generally chronic. So generally chronic lymphocytic we say, we don't say chronic lymphoblastic. Whereas acute we generally say lymphoblastic. So acute is lymphoblastic, acute is myeloblastic, whereas chronic will be myelocytic or chronic will be lymphocytic. So generally whenever it is cytic, it will be chronic. Whenever it is blastic, it will be acute. because whenever it is blast, that means it is immature cell, undifferentiated cell. The rate of proliferation will be extremely high, and the consequences of the immature cells being high in number is very, very serious in nature. Whereas the numbers are high but the cells are mature, the seriousness is little lesser. That is why we put them into category of chronic. So therefore chlorambucil is used in treatment of chronic lymphocytic leukemias. Why it is not used in chronic myeloid leukemia? Because it doesn't have any action on the myeloid precursor cells. It has got significant effect only on the lymphocytic cells. And what will be the adverse effects of this chlorambucil? Again, nausea, vomiting, bone marrow depression. So these are the adverse effects. So they don't have any significant adverse effects like hemorrhagic cystitis, which are unique to cyclophosphamide, ifosfamide. Chlorambucil has got the typical bone marrow depression, alopecia, mucosal injury, infertility. Those are the adverse effects. Now melphalan. Melphalan is also an alkylating agent, and melphalan is one of the preferred agents for treatment of multiple myeloma. Of course, now you have lots of agents for treatment of multiple myeloma, much safer, much better than the alkylating agents. But time-tested drug since long time, chronically, previously used for treatment of multiple myeloma was melphalan. And this melphalan is a prodrug. Again, mechanism of action remains the same. I am telling you the mechanism of action remains same here only as a passing statement, but when you write in the examination, if only melphalan is asked, again you please describe that melphalan is an alkylating agent, it is a prodrug, goes to the liver, gets converted to active form, and it is a carbonium ion. The carbon is in the positive state. Because it is in the positive state, valency is open, it is able to bind to carboxyl group, hydroxyl group, amino acids, phosphate, sulfate groups, can also bind to N7 guanine residue where there is tremendous amount of electrons that are there, and then it distorts the structure of the DNA, collapses the DNA, the cell dies. So that is what is for everyone in the category of the nitrogen mustards, every one of them, the drugs, you have to have this type of mechanism of action being clearly described. Then melphalan, multiple myeloma, and what are the side effects of this melphalan? Of course, as usual, the bone marrow depression will be there, the infections will be there, the mucosal injury will be there, diarrhea will be there, infertility will be there, sterility will be there. Additionally, is there anything? It can cause flu-like syndrome, because whenever tissue cells are injured in large numbers, then there will be certain cytokines that are released, and those cytokines can lead to, for example, interleukin 1, TNF alpha, when they are released, they will lead to flu-like symptoms, that is fever, chills, body ache, headache, fatigue, anorexia, person feeling very dull. So that is called flu-like syndrome, and flu-like symptoms or flu-like syndrome is seen with this. Apart from this, it can cause pancreatitis also. So these are the two important adverse effects that are there, apart from the alopecia, apart from the mucosal injury in the GIT leading to diarrhea, apart from bone marrow suppression leading to leukopenia, anemia, thrombocytopenia, and the leukopenia contributing to infections. It can also lead to flu-like symptoms, and it can also lead to pancreatitis. So those are the features of melphalan. And where is it used? It is used in multiple myeloma. Of course, it can be used in Hodgkin's lymphoma also. So that is about the nitrogen mustards. So in alkylating agents, only nitrogen mustards are asked: meclorithamine, cyclophosphamide, ifosfamide, chlorambucin, melphalan. These are the nitrogen mustards. Then we have ethylene imine derivatives. Ethylene imine derivatives are too toxic to be used orally or intravenously, so now they have been abandoned, and thiotepa, which is one of the alkylating agent, is used only topically in the eye, and that too now it is used post pterygium resection if there is a recurrence. So to prevent that recurrence of pterygium, when you go to ophthalmology, you will study what is pterygium. It is a growth of the conjunctiva over the cornea, and it may go all the way up to the pupillary margin of the cornea, and it may lead to opacity and blindness. And some people generally in this pterygium which is there, which is a thick vascularized conjunctiva growing onto the cornea, if you remove it again, it may grow back, and again you may have to do a surgery. So the recurrence of pterygium in people who are initially operated for that pterygium can be reduced by giving thiotepa as eye drops into the conjunctival sac. So ethylene imine derivatives. Now this is the only alkylating agent which is not a prodrug. Ethylene imine derivatives, thiotepa is not a prodrug. So whenever you have this type of thing, people generally ask Viva questions, and people ask PG entrance questions from this. All of the following are prodrugs except if the question comes. The question says all of the following are prodrugs except cyclophosphamide, ifosfamide, chlorambucil, thiotepa. The answer is thiotepa, because the nitrogen mustards are all prodrugs. Ethylene imine derivatives not. And why do we not use thiotepa? Very toxic. Is it used? Yes. Where? Topically. How topically? Where? In recurrent pterygium to be prevented. Now alkyl sulfonates. In alkyl sulfonates there is a compound called busulfan. So this busulfan is alkyl sulfonate, and this drug has sulfur in its structure. So people who are having hypersensitivity to sulfur may develop allergy to hypersensitivity to this compound. There are certain peculiar features of busulfan. To contrast and compare chlorambucil with busulfan. Chlorambucil we saw works only on lymphocytes, so therefore it is used only in chronic lymphocytic leukemia, whereas busulfan works primarily only on the myeloid series, and therefore busulfan can be used only in treatment of myeloid lineage leukemias and not the lymphocytic lineage leukemias. So busulfan and chlorambucil have a contrasting type of action. One is having a predominant action on the lymphocytes, that is chlorambucil, and the other has got more action on the myeloid series, that is busulfan. So in acute myeloid leukemia and chronic myeloid leukemia we can use busulfan. And why chlorambucil cannot be used in acute leukemias whereas busulfan can be used in both acute and chronic myeloid leukemias is because chlorambucil is slow acting whereas busulfan is rapidly acting. So it can be used in acute as well as chronic leukemias, especially the myeloid leukemias only. Now what will be the side effects of busulfan? Busulfan can cause bone marrow depression, but in the bone marrow depression also, what is a subtle clear difference with busulfan? Busulfan has the ability to primarily suppress granulocytes. Second, it will suppress platelets. Third, it will suppress RBC. So if someone asks what is the sequence in which the bone marrow depression happens with busulfan, which is most vulnerable, which is less vulnerable, the sequence is granulocytes followed by platelets followed by RBC. So first that gets affected with busulfan is the granulocyte. They go down very early if you have a patient on busulfan. Next is the platelets go down. Third is the RBC go down. So this is about busulfan, the sequence in which the bone marrow depression happens. And the next one is busulfan causes another important thing, causes cutaneous pigmentation. These sulfur compounds, they get deposited in the skin and they increase the risk of hyperpigmentation. The exact mechanism is not yet known, could be some extent also phototoxicity, but skin pigmentation increase is very commonly seen with busulfan. The other thing is busulfan can cause pulmonary fibrosis. So this is another important thing. Busulfan can cause pulmonary fibrosis. So if anywhere busulfan's side effects are to be highlighted, one is pulmonary fibrosis, other is cutaneous pigmentation or skin pigmentation. The third one is bone marrow depression, especially the myeloid series getting the most impact in terms of the granulocytes going down, the platelets going down, and then the RBC going down. Where it is used in myeloid leukemias only, not in the lymphoid series leukemias, because busulfan has got a very low affinity to enter into the cells. Now why do you think this chlorambucil busulfan have this predilection, like chlorambucil only for the lymphocyte mediated precursors and busulfan only for the myeloid precursors? That is basically because all these cells on their surface they have certain transporters, and these alkylating agents use these transporters to get into the cell. The type of transporters that are expressed on the lymphocytes are more favorable for chlorambucil, and the type of transporters that are expressed on the surface of the myeloid precursors are more favorable for busulfan, and that is why busulfan gets more into the myeloid cell series, whereas the chlorambucil gets more into the cell lineage of the lymphocytes. So that is the reason why you get a distinction between chlorambucil and busulfan. Busulfan, never forget pulmonary fibrosis, never forget skin pigmentation. Additionally, do not forget that the hematological toxicity is not uniform, it is a differential. For example, the granulocytes affected more, second platelets, third RBC. So that is the differential way in which the hematological parameters are affected with busulfan. Then alkylating agents, I will complete all of them, it won't take much time, is nitrosoureas. These end with the suffix mustine. Carmustine and lomustine. Carmustine is now not used because of its significant toxicity. Now we use lomustine. Theoretically, you need to know both the names, carmustine and lomustine. So these are nitrosoureas. There are certain peculiar features of these nitrosoureas, and the peculiar feature of these nitrosoureas is that these are highly lipid soluble compounds. Because these are highly lipid soluble compounds, they have excellent oral bioavailability. Not only excellent oral bioavailability, they cross the blood-brain barrier significantly. So nitrosoureas are primarily used in treatment of brain tumors. And apart from that, any tumor that infiltrate into the central nervous system. For example, you might have studied ALL. There is a meningeal involvement in ALL. There is a CNS involvement, and that is an indicator of bad prognosis. So in ALL you have good prognostic signs, bad prognostic signs. So involvement of the meninges and the brain is a bad prognostic sign in ALL. Now when brain tumors are there, or when any tumor invades into the central nervous system, then these compounds are useful because these compounds are highly lipid soluble. They cross the blood-brain barrier significantly and therefore can exert a very significant cytotoxic effect even in the central nervous system. Apart from this, are there any specific features of these nitrosourea, specifically that lomustine? The other specific features are these drugs are nephrotoxic. Till now we didn't come across drugs which are nephrotoxic in alkylating agents, but lomustine is nephrotoxic. Apart from lomustine being nephrotoxic, does it cause anything else? It does cause some other adverse effect, that is not only nephrotoxicity, additionally it can cause visceral fibrosis. So most of the visceral cells that get injured, when they recover, they will be actually covered in a sheet of fibrous tissue. Whenever cell death happens, the natural reaction will be fibrosis, and this lomustine, wherever it is going, because it is highly lipid soluble, it will get into lot of tissues, and after getting into lot of tissues, it will kill even the normal cells in those tissues, and when the tissue has to recover from it, it has no option but to recover by fibrosis. So visceral fibrosis and nephrotoxicity are two important adverse effects of lomustine. Other than that, it can also cause nausea, it can also cause vomiting, it can also cause bone marrow depression. So those are adverse effects that are already there, and CNS manifestations could be there, and peripheral neuritis can also be there with this lomustine, because it is so lipid soluble that it can get into the peripheral nerves also. It can get into the myelin sheath of these neurons and then lead to peripheral neuritis. So peripheral neuritis is possible. It can cause nephrotoxicity, it can cause visceral fibrosis, nausea, vomiting, diarrhea, infertility. As all other drugs, it is still there. But what is the peculiar feature? They are used in treatment of central nervous system tumors, or tumors that infiltrate into the central nervous system, like ALL infiltrating into the CNS with meningeal involvement. Then there is another group of compounds called triazine group of compounds, where you have these two compounds, dacarbazine and temozolomide. This dacarbazine is important to know because dacarbazine is used in treatment of malignant melanomas and Hodgkin's lymphomas. And this dacarbazine is also a highly irritant compound, and dacarbazine is given only intravenously. Orally and all it is not given because it is highly irritant. Nausea, vomiting will be severe. So dacarbazine is given only intravenously. The two important conditions where it is used is malignant melanoma and Hodgkin's lymphoma. All other adverse effects will be same. It can cause mucosal erosions in the GI tract, it can cause excoriation of skin, it can cause loss of hair, it can cause bone marrow depression leading to secondary infections, and it can cause severe nausea, vomiting even if you give IV, and it can lead to occurrence of secondary malignancies if it is used for a long term. Then there is an oral congener in the triazine category, because I told you dacarbazine cannot be given orally, that is temozolomide. The indications more or less are same. It is used, temozolomide is used even in malignant melanoma. It can be used in Hodgkin's lymphoma, but primary use of temozolomide is in central nervous system tumor, glioma. So temozolomide has shown excessive ability to halt the progression of the glioma. So temozolomide is a triazine derivative. It can be given orally, and it has got less adverse effects than that of dacarbazine. So whatever adverse effect of dacarbazine you can see, a very moderated version of them. For example, the irritability in terms of nausea, vomiting is low, GI irritation is low, alopecia and all will be relatively low, bone marrow depression will be low. So if you compare dacarbazine and temozolomide, the adverse effects are low. It is well tolerated. It is used in Hodgkin's as well as malignant melanoma, but primarily it is used in glioma. Then the last one, methylhydrazine, procarbazine. Procarbazine again is not used nowadays because of its significant potential to interfere with the DNA in many sites apart from the malignant tissue. So of all the alkylating agents, if you compare procarbazine has got much potential to leave the cancer cells and enter even into the normal cells. Leave the cancer cells in the way I mean is not that it doesn't go into the cancer cell. It goes into the cancer cells, but its specificity is so poor that it doesn't really interfere with only the cancer cells and kill the cancer cells. It actually interferes significantly with cells in normal tissues of the body also in large proportions. And therefore, the DNA injury that results from procarbazine is responsible for occurrence of cancers. So the occurrence of cancers among all alkylating agents is highest with procarbazine. So you need not get confused when I say that anti-malignancy drugs themselves can cause malignancies. I told you the reason also. So anti-malignancy drugs not only eliminate the malignant cells, but they also eliminate the cells in our body which actually take care of the rogue cells in the body. The rogue cells are those cells which are on the process or in the process or on the route to becoming malignant. So natural killer cells actually eliminate them. So if the natural killer cells are also eliminated by an anti-cancer agent, that itself may increase the risk of malignancies. So that is how most alkylating agents can theoretically increase the risk of secondary malignancies, the risk being high with procarbazine. So procarbazine is not used commonly. Another two important features of procarbazine that you need to remember always is procarbazine is a monoamine oxidase inhibitor. Because it is a monoamine oxidase inhibitor, it can cause CNS manifestations. Because monoamines are noradrenaline, serotonin, dopamine. So these monoamines, when their levels are elevated, they may cause CNS stimulation and they may lead to seizures. Not only that, there will be cheese reaction if someone takes procarbazine and then simultaneously takes food which contains monoamines. For example, cheese is rich in monoamines, biological monoamines. Now when someone is already on procarbazine, the biological monoamine in the diet will not be metabolized, it will get absorbed. And you know, some of the monoamines, they can release the endogenous monoamines. So these monoamines in the diet can go and release the endogenous noradrenaline and serotonin, and the noradrenaline can cause severe rise in blood pressures. That is what we call as cheese reaction, for which we use alpha blockers. So procarbazine can theoretically increase the risk of that cheese reaction because it is a monoamine oxidase inhibitor. It increases theoretically the risk of seizures because it is a monoamine oxidase inhibitor, can elevate levels of stimulatory neurotransmitters, that is noradrenaline and serotonin. Apart from that, the other one is procarbazine can also inhibit aldehyde dehydrogenase enzyme. And you know, alcohol is metabolized in two steps. First is alcohol dehydrogenase, next is aldehyde dehydrogenase. So the aldehyde dehydrogenase enzyme is inhibited by procarbazine, because of which the acetaldehyde that is formed as a intermediary product of ethanol metabolism will not get converted to acetic acid, and acetaldehyde, when it accumulates, it will lead to nausea, vomiting, headache, dizziness, fall in blood pressure, sometimes convulsions, coma and death. So that is what we call disulfiram like reaction. So disulfiram like reaction is also common with procarbazine. So few things about procarbazine. Is it used commonly? No. Is it an alkylating agent? Yes. Is it a prodrug? Yes. Mechanism of action? Same as other alkylating agents. Adverse effects? Same as most alkylating agents. Are there any additional adverse effects? Yes. What are the additional adverse effects? One of them is that it has monoamine oxidase inhibiting potential, can cause CNS stimulation, can cause seizures. It can cause cheese reaction because it is a monoamine oxidase inhibitor. The next one is procarbazine can cause disulfiram like reaction if someone takes alcohol after taking procarbazine, because procarbazine is inhibitor of aldehyde dehydrogenase, and when you inhibit aldehyde dehydrogenase, alcohol metabolism is stopped and alcohol will not get converted to acetic acid finally. Normally ethanol, when it is taken, alcohol dehydrogenase converts it to acetaldehyde, and acetaldehyde dehydrogenase converts it into acetic acid. Now if you take procarbazine and in a person who has taken already alcohol, what happens is his alcohol will get converted to aldehyde, but aldehyde will not get converted to acetic acid because the aldehyde dehydrogenase enzyme is blocked by procarbazine, and that is how the person may develop disulfiram like reaction. So these are the things in the alkylating agents. When the afternoon I come, I will start with platinum coordination complexes that are used in treatment of cancers. Very essential drugs in wide range of cancers, and they have very interesting features associated with them. Then I will also tell about another big category of drug called anti-metabolites. Most often in 4-mark question you get either anti-metabolites or platinum coordination complexes. So if you would like to learn more about them or hear more about them, in fact, in the afternoon about 2 o'clock in the pharmacology class, I will come back and discuss about the platinum coordination compounds and also the anti-metabolites.